Okay, so I want to welcome everybody to this webinar. We do have a lot of ground to cover today, so I'm going to go ahead and go over a few things to get us started. My name is Jennifer Caputo. I'm a senior research associate in the public health practice at Westat, and I'm part of the team for the SAMHSA Center for Financing Reform and Innovation contract, or CFRI, which is what we call ourselves for short. I'm so excited to welcome you to today's webinar. It's titled Revised Regulations for Opioid Treatment Programs, Establishing a Baseline to Measure Progress Over Time. So during today's webinar, we will be reviewing findings from the newly released SAMHSA report with the same title, which examines how states in opioid treatment programs, or OTPs, are adapting to the revised 42 CFR Part 8 regulations. And you should be able to see a link to that report in the chat, so you can go ahead and take a look at that. We'll also have a panel discussion and a question and answer session during which we'll hear perspectives on and experiences with implementing the revised regulations from the state, OTP, and federal perspective. We've had a ton of interest in this webinar, so over 2,000 people have registered. And I'm just taking a look at the counter that's quickly going up, and we already have over 500 people that have joined. So super exciting to see that so many people are just really invested and interested in this topic. And I'm sure that the information will be useful for a lot of different audiences. So while we wait for just a couple more minutes for others to join, I'll cover a few housekeeping items. So first, this webinar is being recorded. The recording and slides will be posted on the SAMHSA website in about 10 business days, and we'll email all registrants to let you know where you can find those when they're posted. Another thing I'd like to note is that everyone except for today's presenters is coming into the webinar on mute and with your videos turned off, and that's just going to help us maintain a really high quality recording for posterity. And then I'd like to draw your attention to the Q&A widget at the bottom of your Zoom screen here. So please use that widget to type any questions that you have for our speakers. You can type into it at any time during the webinar, and at the end we'll have a few minutes for Q&A, and we'll get to as many of those questions that we can. We also do have staff just monitoring those questions in real time, so if you have any kind of technical difficulties that you want to help with, feel free to ask for that help in the chat and somebody will reach out to you. And then last thing, we have the chat feature. I don't think I need to say much about that. I see you're already popping things in there. That's where you can just communicate with the other participants. So feel free to use that to let others know where you're from as you're doing and maybe what the weather's like where you are today. Okay, so on to the next slide, please. So to start us off today, I'd like to tell you just a little bit about where this webinar fits within the overall Center for Financing Reform and Innovation Task Order. Again, we call that CFRI for short. So CFRI is a SAMHSA contract, and Westat, where I work, is the prime contractor. We're an employee-owned company headquartered in Bethesda, Maryland. I've been working on the CFRI contract for several years now, and it's been one of my absolute favorite projects. We do all kinds of really interesting and important studies related to mental health and substance use disorder prevention and treatment and the financing of those services. And I've personally learned so much from working with the SAMHSA team on this contract. So if you want to learn more about our many other wonderful CFRI projects, please do check out the CFRI website that's listed here at www.samhsA.gov/LIBRARIES/CFRI. And you can also see a link to that website dropped into the chat. Okay, next slide. On to our agenda for today. During today's webinar, you'll first hear from Dr. Karen Phillips from SAMHSA, who will share some opening remarks. Then Ricky Welch at Westat will provide a short presentation of the report findings that you can see here. Her presentation will then be followed by a 30-minute panel discussion. We have a great panel for you, and that will be moderated by Nicole Smith at SAMHSA. And then last, we'll have some time towards the end of the webinar for a Q&A where we'll ask just as many questions that you pop into that Q&A that we can. So now let me go ahead and introduce our first presenter, Dr. Karen Phillips, the Acting Director of SAMHSA's Center for Substance Abuse Treatment. Dr. Phillips leads national efforts to expand access to high-quality evidence-based treatment for substance use disorders. She brings deep experience as an addiction medicine and internal medicine physician, with more than 14 years at the National Institute on Drug Abuse, leading clinical research on opioid use disorder, global health innovation, and recovery. She also continues to provide low-threshold buprenorphine treatment through a mobile care unit serving justice-involved individuals in the surrounding community. With that, I'm so pleased to turn it over to Dr. Phillips.
Thank you, Jennifer, and good afternoon, everyone from Rockville, Maryland. I'm so glad that you all can join us today to discuss SAMHSA's new CFR report on the revised regulations for opioid treatment programs. We're really grateful to have such a broad and committed group of leaders and providers and practitioners from across the nation with us today. As you know, in 2024, about 5 million people aged 12 or older were reported to have a past year opioid use or an opioid use disorder, of which only 17% received medications for opioid use disorder or MOUD. Opioid treatment programs play a critical role in our treatment continuum. OTPs provide comprehensive, evidence-based treatment for OUD, integrating medications with counseling, screening, and health services, including prevention and treatment of infectious diseases. 42 CFR Part 8 are the federal regulations that govern the certification and operations of our nation's OTPs, and these set the standards for safe and effective use of MOUD. In February 2024, the Department of Health and Human Services and SAMHSA published revisions to 42 CFR Part 8. This represented the first substantive change in the regulations in more than 20 years. The revisions took historic steps to increase access to MOUD and advance retention and care by promoting patient-centered, compassionate interventions and practitioner autonomy, removing stigmatized and outdated language, and reducing barriers to service access. These changes have the potential to continue to produce significant cost savings, health benefits, and most importantly, reduced mortality. The SAMHSA report we're going to discuss today offers an early snapshot of how these revisions are being translated into practice. The report provides a baseline understanding of how states and territories have adopted the revised regulations, examines how OTPs are implementing these changes in practice, and explores key barriers and facilitators affecting implementation. During our panel discussion, we will hear from OTP state and SAMHSA leaders who will share strategies to effectively implement the updated regulations and offer perspectives on how these changes have improved care for individuals with opioid use disorder. This work builds on SAMHSA's continuing efforts to expand access to comprehensive, evidence-based, patient-centered recovery, treatment and recovery support services, and national efforts to prioritize and strengthen addiction treatment and recovery. With that, I want to thank you all again for joining us for this important discussion, and I'll turn it back to Jennifer.
Great, thank you so much. So now I'm going to introduce my colleague, Rikki Welch. She's a principal research associate at Westat who led this project from the Westat side. Rikki has more than 24 years of experience leading qualitative and mixed methods research projects, conducting trainings, and writing manuals and reports for federal health clients, including multiple CFR studies for SAMHSA. And today she's going to provide an overview of the report findings. So let me go ahead and turn the floor over to you, Rikki.
Thanks, Jennifer. Good afternoon, everybody. I'm excited to share the results of our baseline study with you. First, though, I'd like to define some terms. As Dr. Phillips mentioned, Part 8 of Title 42 of the Code of Federal Regulations, commonly referred to as 42 CFR Part 8, contains the federal regulations for services provided in opioid treatment programs, which are commonly known as OTPs. OTPs are certified licensed facilities that provide medications such as methadone or buprenorphine for opioid use disorder. OTPs can also provide counseling, screening, and health education services. OTPs are certified by SAMHSA, they're licensed in their state, registered with the Drug Enforcement Administration, and accredited by an independent SAMHSA-approved accrediting body. The regulations in CFR Part 8 outline the standards for services provided in OTPs. Next slide. In 2024, SAMHSA and the Department of Health and Human Services published the first significant changes to federal OTP regulations in several decades. These revisions permanently incorporated several temporary flexibilities that had been introduced during the COVID-19 pandemic, after evidence showed that these changes had positive effects on patient care and safety. Specifically, the changes permanently incorporated some greater flexibilities in allowing take-home doses of methadone and the use of telehealth to initiate methadone or buprenorphine treatment. They also eliminated specific admissions requirements, such as the 1-year opioid addiction history and 2 documented instances of unsuccessful treatment for people under the age of 18. Some other changes that promote greater access and retention include, for example, allowing nurse practitioners and physician assistants to order MOUD for dispensing at the OTP as permitted in their state. Next slide. Now to the report. The purpose of the report is to provide an initial understanding, a baseline, so to speak, of the extent to which states and territories had adopted and OTPs had implemented practice changes shortly after the updated regulation went into effect. So in terms of timeline, the changes to 42 CFR Part 8 went into effect in April 2024, but SAMHSA had set a compliance date of October 2024 to allow states and OTPs time to prepare for the revisions and review state-specific regulations. This report provides a baseline for understanding how those changes were put into practice at OTPs across the country shortly after the compliance date, which was October 2024. It serves as a benchmark for future research. The report examines several research questions among states and territories and OTPs, including, for example, which change elements initially had higher and lower adoption and implementation rates, and to what extent adoption and implementation may increase over time. It's important to note that while federal regulations in 42 CFR Part 8 set the national parameters, states and territories can opt to have their own stricter requirements than those outlined in the federal regulations. OTPs need to align their services with state-level standards for OTP service provision. Next slide. Between December 2024 and February 2025, the National Association of State Alcohol and Drug Agency Directors, which you may know as NASDAD, and the American Association of Treatment of Opioid Dependence, which you may know as ATOD, distributed a survey to OTPs and state opioid treatment authorities, known as SOTAs, to better understand adoption and implementation of the updated federal regulations. Excuse me. SOTAs are state employees who serve as liaisons between OTPs in their state and SAMHSA, and the single state agency overseeing drug treatment in the state. SOTAs link OTPs to other state agencies, such as Medicaid, and they monitor OTP operations for quality and compliance. SOTAs also provide guidance to OTPs on navigating any discrepancies between state and federal agencies. In total, 241 OTPs representing 39 states and 46 out of 52 SOTAs responded to the survey. OTPs shared which changes had been implemented within their programs, and SOTAs provided insights into which changes had been adopted within state regulations. Next slide. As I mentioned previously, findings represent the proportion of states and OTPs that had adopted the changes shortly after the revisions went into effect. And in terms of adoption and implementation, 37% of responding SOTA members reported that their state or territory had adopted all 13 practice changes aligned with the updated regulations. But a much larger proportion, 85%, had adopted over half of the changes. And across responding OTPs, about 70% had adopted more than half of the changes. Next slide. Across the states, the most frequent changes to state regulations after the revised CFR Part 8 went into effect include using drug testing as one data point rather than a sole determinant to inform clinical and medical decision-making, allowing take-home doses of methadone in certain circumstances from the first week of treatment, and allowing OTPs flexibility in treating medical and psychiatric comorbidities. Comparatively, the most frequently implemented changes among OTPs include updating criteria for take-home methadone doses and eliminating previous admissions requirements. And this includes the 1-year opioid addiction history requirement and 2 documented instances of unsuccessful treatment for individuals under 18. Next slide. SOTAs and OTPs also provided information on which changes were least frequently adopted and implemented, and you can see some of those here. Please keep in mind that the fact that they had not yet adopted or implemented the change at the time of the survey does not mean that they didn't plan to implement the change. So for example, while only 65% of SOTAs at the time of the survey had adopted the change to allow access to medication without making it contingent on counseling attendance, 38% of those SOTAs who had not yet adopted the change indicated that the change was under consideration in their state, and 19% indicated that the change was in process. Next slide. States and OTPs shared insights on the benefits of adopting and implementing the updated regulations. Several of them that were reported included increased patient retention, and this resulted from higher doses available at induction and additional take-home dose opportunities, stabilization of current patients through take-home dosing, improved patient experiences centering on the patient, and increased patient admissions. Taken together, these benefits illustrate the ways the 42 CFR Part 8 revisions improve access to care for patients. Next slide. SOTAs and OTPs also shared several opportunities to increase uptake of the regulation changes and strategies to address existing challenges. And among those are, number one, mindset change. Many of the surveyed members mentioned that this is an area in which there were opportunities for improvement. We heard that incorporating the changes in CFR Part 8 may be difficult for organizations or practitioners who've applied a very specific approach to OUD treatment for a very long time. We also heard that having one-on-one conversations with their SOTAs may help OTP practitioners see the benefits to change incorporation. Funding was also sometimes a challenge for change implementation across the OTPs. Reimbursement rates and mechanisms, including those through Medicaid, don't always support the larger number of take-home doses. And opportunities to mitigate these financial strains include things like moving to a fee-for-service model and unbundled payment strategies to help offset costs for take-home doses and other expenses related to keeping locations open. Another strategy for expanding access is pursuing partnerships with other local clinics. For example, some OTPs are working to create satellite offices in partnership with federally qualified health centers, and this can help expand the capacity of existing OTPs to reach more patients. That's it for the summary of the report, and I'm going to turn it over to Nicole Smith, our panel moderator. Nicole serves as branch chief of the Regulatory Programs branch within SAMHSA's Center for Substance Abuse Treatment, Department of Pharmacologic Therapies. And in this role, she leads a team responsible for the oversight of OTPs nationwide. Nicole?
Thank you, Ricky. I would like to begin by introducing our panelists. First, we have Dr. Patty Juliana, who is the Director of the Division of Pharmacologic Therapies in SAMHSA's Center for Substance Abuse Treatment. As a clinician and federal leader, she has specialized in treatment of substance use disorder and leads national efforts to strengthen SUD care, particularly opioid treatment programs and evidence-based practices. She has led SUD services in academic and community settings for more than 30 years and provided technical assistance to states and treatment services. Her work focuses on integrating SUD and general medical care to improve access, quality, and outcomes. Dr. Juliana holds a doctorate in social work and as a licensed clinical social worker in New York and a certified trauma professional. Next, we have Chrissy Martin, a licensed marriage and family therapist and licensed addictions counselor from South Carolina. She has worked in the field of opioid treatment for close to 20 years in a variety of roles, including as a counselor, a clinical supervisor, and a program director. Chrissy currently works as a national clinical director for Behavioral Health Group, the largest network of Joint Commission accredited outpatient opioid treatment programs in the country. She is the current chairperson of the South Carolina Association for the Treatment of Opioid Dependence and represents South Carolina on the board of the National ATOD, where she serves as the membership chair and as a member of the legislative committee. Next, we have Dustin Metz, who is the CEO of the Columbus, Ohio-based behavioral health nonprofit CompDrug. As a teenager, Dustin was an active participant in CompDrug's youth-to-youth prevention program, which had profound impact on his career. Dustin was one of the originators of the Ohio Association for the Treatment of Opioid Dependence and serves as the Ohio delegate to the National ATOD, as well as a trustee of the Ohio Council. He has a Bachelor of Science in Communication from Ohio University and a Juris Doctorate from the University of Dayton School of Law. And finally, we have Adam Buchan, who serves as the State Opioid Treatment Authority, SOTA, for New Jersey, and is the current president of the Opioid Treatment Network, OTN, a component of the National Association of State Alcohol and Drug Agency Directors, NASDAD. He oversees the day-to-day monitoring and regulatory oversight required to implement SAMHSA's regulation related to the use of medications for treating opioid use disorder. Let's begin with our first question. The revisions to 42 CFR Part 8 represent a major shift towards more flexible, patient-centered care for the treatment of opiate use disorder. From your perspectives, what changes, successes, or promising practices have you observed within your state or program since the revisions went into effect in 2024? Let's begin with Adam.
Thank you, Nicole. Definitely a great question. And I think one of the major things that we're seeing, especially what I'm hearing from opioid treatment programs that I work with in the state, is that there is more individualized care. So it's really helpful that there's been the movement away from a one-size-fits-all approach. We're also seeing that many OTPs are reporting take-home flexibility has reduced treatment barriers and retention in treatment. A couple other things that we're seeing, at least from our state side, is that there has been a reduction in medication or Medicaid transportation costs for patients that were going daily for their take-home medication. So, you know, we haven't run a large-scale report, but we have looked at a couple of our larger opioid treatment programs in the state, and we have seen that reduction. So a cost saving to states is always a good thing as well. The last thing I really want to mention, and something that I really think has been the most beneficial, is the improved coordination across systems. There's really more coordination, especially through telehealth, through OTP partnership with emergency departments, skilled nursing facilities, and correctional facilities. The ability to do telehealth in those settings and maybe even induct people onto methadone or other medication has been so instrumental to making things better, really, you know, across our state at least.
Awesome. Thank you, Adam. Next, we will have Chrissy.
Yeah, I would just add to what Adam already shared. I think one of the successes that we're seeing is really the impact on admissions in the OTP. And really what I'm talking about is the threshold for admission into the OTP setting. You know, we're no longer having to screen for things like that kind of arbitrary one-year history of addiction. And we certainly have more options, more flexibilities when individuals present with some legitimate barriers or transportation difficulties or difficulties around attendance.
But as Adam was mentioning, that those telehealth capabilities have been really important. Also, the expanded scope of use of advanced practice providers in the OTP setting, the expanded scope of services we can deliver through mobile units and medication units, all of that has had amazing impact on our admission capability. It's allowed for programs to be much more responsive, to be able to meet individuals kind of in that really important moment of readiness. We know that it takes a lot to build up to that decision to seek help. And so these changes have really helped providers ensure that when those individuals are in that moment of readiness, they're being met with an open door.
Thank you, Chrissy. Next, we'll have Dustin.
Yeah, everything above. What I would add is I think that the impact on the patient, the person receiving service, whatever you would call them, that's been transformational because the focus has shifted away from a look at the rules, the executing on the how we do it, and looking more at what is the impact on the patient and what does the patient need. That was, I think, the beauty in the regulations and the adopting them, but also the impact for the patient has been huge.
Definitely. And lastly, we have Patty.
Thanks, Nicole, and thank you, everybody. I'm glad to see everyone here, including the listeners. We've been able to see impacts in a couple of different ways. We see them from requests that come in for some very creative responses to patient needs. We get to see, we have seen more increased collaboration among services and other settings. So there's much more of an open-mindedness. We have the DPT mailbox where we do get comments still from patients and OTPs alike. And we do hear from the SOTAs pretty regularly too. So we have many different ways of seeing that there's much more of a focus on increased collaboration with other services. We have had opportunity to witness the expanded access to treatment with the changes in the criteria. And we've also had the opportunity to see an expansion in the reach of the programs through many, many more medication units popping up across the country. So those are some of the key ways we've seen the ripple effects of more convenient rules, or rules that fit the context of the person's life more effectively.
Thank you, Patty. Our next question. One of the core goals of the revised regulations was to increase flexibility, specifically take-home doses and telehealth initiation of medications for opioid use disorder. How have these flexibilities impacted clinical decision-making, patient engagement, or retention in care thus far? Let's begin with Dustin.
I think it's affected across the board. It's shifted the mindset to motivation rather than mandating. And that may seem simple, but it's transformational. OTPs are getting more comfortable with exercising greater discretion in balancing safety, patient preference, other factors in ways that we frankly did not have the leeway to do before. We're discovering things like physical presence is a rather poor proxy for a strong therapeutic relationship. Just because someone's there every day doesn't mean that you're actually connecting with them and doing the important work you need to do, which what the regulations now provide. Another aspect was how do we implement these? In thinking through what we need to do, we really need to reevaluate, how implementation, use of peers, and critical in motivating and supporting the recovery journey. Use of technology. Automated dose assembly allows us to provide a large number of doses for the take-homes, split doses. We don't need to make decisions based upon what our nurses, or in whatever state you're in, who can provide them, but rather what is best for the patient, including not having to travel. So utilizing technologies such as a virtual dosing window allows us to safely monitor the use of those take-homes so that we're in essence daily dosing, but they're not coming into the clinic. They're not leaving their context. The patients are living their lives and in recovery. And it allows us to spend more time doing the therapeutic relationship, looking at medication adherence, and the 20 to 30% that need more services and how we're motivating them to get those services.
Awesome. Thank you, Dustin. Next, we'll have Chrissy.
Yeah, I think Dustin stated it really well. It certainly changed the lens that our providers use to make clinical decisions. It's no longer about kind of following the rule book. It's much more about, what makes sense for this person in front of me in this moment in time. So much more ability to kind of engage in that shared decision making and to individualize care delivery, which of course directly relates back to how that patient experiences their treatment and whether they choose to keep coming back.
Thank you. Our next question. What changes do you feel are the most beneficial to OTPs and patients? Let's begin with Chrissy.
Yeah, I think, from the provider perspective, again, that ability to be more available for admissions, I think has been really valuable in terms of, meeting the needs of our communities, the communities that we serve. But from the patient perspective, I think I have to point to the take-home flexibilities there. It's just been such a game changer. Both in terms of, addressing kind of some of those true transportation, true attendance kind of barriers, but also I think just like the feeling of treatment, right? Coming to treatment should never feel like a burden. Coming to treatment, it should feel like coming to a place of refuge. And, I think as providers, we certainly still have to think about risks. Diversion and misuse are still realities that we have to consider and safeguard against. We never want these medications to cause harm, but over the years, I have to say, I've known many individuals who were really not at risk for diversion, for misuse, and because of maybe their time in treatment or how those criteria would get applied or interpreted, they still had this kind of high burden of attendance that was really beyond what was clinically necessary to support them in their treatment and their kind of recovery needs. So being able to do that true kind of risk benefit assessment and to make those decisions based truly on what the clinical needs are of each individual has been quite a benefit to patients for sure.
Thank you. Dustin?
Yeah, we did some looking at it internally, and only 2.5% of the patients that we surveyed were not happy with the changes. 70% were very satisfied, and a net promoter score of 75, which is really good. I think it highlights, if I could, just two quick statements from feedback we received from patients. This was on March 16th. I work full-time from 8 to 5:30 every day. I'd have to use my lunch hour to come down and dose, and I did that for a long time, but this is a much better way to do things. I get to spend more time with my family. I think it's awesome. And now I actually get to sit down and enjoy my lunch on a daily basis and get a little rest instead of driving down there and then back to get to work and have to do that all within an hour. On January 8th, having no car, relying on family for rides, trying to work, take care of myself and a sick pet, and all of that. The changes really make life much more obtainable. I think that highlights it.
Thank you so much, Dustin. We appreciate you sharing. Next, we'll have Adam to share from the state perspective.
Okay, and I do think that both Chrissy and Dustin really hit the nail on the head. I do think the most important things that I've seen really for the patients and the OTPs themselves is the increased take-home flexibility as well as the use of telehealth. I think it's really been able to expand the use of treatment. It's been able to meet people where they're at. It's also, for the OTPs themselves, you don't even need to have the prescriber specifically on site to do any type of new induction. So it helps link people to treatment right away when they need it. The other thing I do want to say is that most beneficial to OTPs, I think our state is currently exploring that. We actually partnered with Johns Hopkins University School of Public Health to do a survey of all of our opioid treatment programs to kind of assess what these changes have done, what these changes have meant. And then we even went one step further. And actually this week, there are, patient roundtable discussions occurring. Actually, not just getting information, feedback from the OTPs themselves, but actually from the patients, seeing what these changes have meant to them. Have they seen the changes? I think that's part of my role, is to, if some of these agencies aren't, implementing these changes, really to go out and have those discussions and stress really why it's so important and how it leads to better patient care. So thank you.
Thank you, Adam. And we have Patty to share from the federal perspective.
Go forward, Nicole.
Okay, no problem. Our next question. Did you have any barriers to adopting the new regulations, such as state laws or organization policies that required updating? If so, what was done to remove the barriers, and what advice would you offer other states or programs that are still in the process of adopting or implementing the changes? Let's begin with Adam.
Okay, well, I do think each state probably experienced their own challenges. I really call them hurdles or speed bumps, just things that you have to, break down the barriers to get through. But I think in our state, what had occurred was, we had a set of regulations. It probably took us about a year to get a process, which our Department of Health issued a waiver to align with the federal regulations. So, in my state, I'm with the Department of Human Services, but then our Department of Health is the licensing authority. So I think what had to happen was the communication with other state departments to really, assess what these changes would mean. Just go through whatever, process was needed to implement this change and then activate it. I think, again, that's just one step, is our state aligning with that. Now it's really on to the opioid treatment programs themselves, because there are so many, and they're probably all in a different process. There's different, staff members at the agency that have different beliefs, worried about liability. So it's really my job, and I think other state opioid treatment authorities' jobs, to go out to these facilities to have those discussions. So what I would recommend is, I think a lot of states have aligned with this, but there's always different, barriers that come up. I think communication is really key. Talking with the other state departments, the other stakeholders, accessing information from the patients themselves to really implement these changes, really get, we even use a professional advisory committee to give us recommendations for, changes that are needed in the field. So I think that's really the key. Since I've been working in state government for 21 years, I felt like communication is really the key to every success.
Thank you. Thank you so much, Adam. Next, we'll have Chrissy.
Yeah, I'll just share that, at Behavioral Health Group, we operate in 20 states plus the District of Columbia. And so, navigating all these, different and sometimes multi-layered state systems, as they've all engaged in kind of their unique rulemaking processes and all at varying paces, has probably been our biggest challenge. As we see kind of clearly articulated in the report, there have been a lot of differences. There's full adoption states, partial adoption states, states that have not adopted, and also states that kind of layer in additional rules of their own, kind of outside of what's addressed in 42 CFR Part 8. There are states where we're still waiting on the rulemaking process, where we're operating under waivers. And then I would also add, there's, often additional layers that we have to think about. What are the telehealth policies in each state? What are the, what's scope of practice for advanced providers in each state? So very complex. We've had to be very thoughtful about that, very nimble, I would say, in our internal policy amendments as we've kind of rolled that out. I think my advice to providers would be, one, be plugged in, pay attention to kind of what's happening in your state, make sure that you're plugged into email communications, that you're, if you have kind of a state aid chapter or whatever, that you're in that network, that you're getting those and receiving those communications. And then as you roll that out in your programs, having good strategies around evaluation, communication, implementation, collecting data, collecting feedback as you roll that out. And for states, Adam did such a nice job illustrating that, ideal structure of communication between providers and state agencies. I think where we found this to be the least painful, most painless, has been in states where there's been really good communication, really good collaboration between the state authority and the providers, and lots of opportunity for dialogue, feedback, and also good technical assistance from the state.
Thank you, Chrissy. And Dustin?
We're talking about multiple layers. There's one additional layer, and that is the fact that while the rules and regulations define what we can do, and the OTP decides what within those regulations it wants to do, at the end of the day, we all need to make sure we're able to provide the services, and a payer gets their say. And they're not necessarily at this table, but they have a really strong influence on whether or not you can successfully roll out the changes within the environment. So deal with everything else that's already been said, and then how do you actually do it in a way that you can get reimbursed to provide that service, because you have to. So it is another layer to consider.
Thank you, Dustin. I just want to provide an opportunity for Patty, if you want to chime in on this one.
Sure, thankfully. We know that different states are at different levels of adoption of the revisions. Many of the states have implemented waivers, statewide waivers, where actual regulatory transitions or changes take more time than in others. We can remind everyone that states can't write rules they can write rules that are less restrictive than what we have as the federal government, but the OTPs are obliged to commit to whichever is the more restrictive in any given moment, which is always a challenge for people who are new to the field, especially in new OTPs. I do want to take the opportunity to remind everyone that we also have a waiver process that is exemptions. If it's a program-wide exemption, it might be more, please confer with your compliance officer or with DPT. We'll put the DPT mailbox in the chat so you have it. But waivers can always be requested. It is my favorite. It's even more favorite for me than the take-home exceptions. My favorite exception rule in the Part 8 is that there is a possibility to request an exception from any of the other rules. So that's my marketing for think about what you need to do, what you want to do, and we'll hopefully collectively figure it out together.
Thank you, Patty. Our next question: how are patients reacting to the changes? In what ways, if any, have the revised regulations changed how patients experience care or stay engaged in treatment? Let's begin with Dustin.
I won't bury the lead. Our 90-day retention increased 17%, period. We challenged that data. We looked at it. Is this right? Is it? Yeah. John, it was impressive. Now we tried to identify why, and the factors that we came up with were all related to the Part 8 changes. Higher starting doses, quicker increasing to take homes, the virtual dosing window, implementation of what we were doing to meet all of those challenges. It was very evident in what we looked at. We also looked at, for our longer term patients, where are we? Prior to the pandemic, we did not, as a provider, provide anything more than 2 weeks of take homes. That's where safety, it's where we did it. What we learned through the pandemic, what we learned through how to implement what became the Part 8 changes, less than 10% of our census now has less than 1 week of take home. And only 0.8% of our census has daily take homes. And all of them, they need them, as opposed to that's what they have to have. And I think it highlights the importance of implementation of these rules, because it does make a difference to the patients on a daily basis.
Definitely. Thank you, Dustin. Next, we have Chrissy.
Yeah, I think in my organization, we've really tried to approach this not just as a rule change, but truly as a culture change. And I think Dustin really touched on that. And I saw a really great kind of comment in the chat from someone with lived experience that said, I was already receiving the max amount of take homes. What is this kind of doing for me? And my hope is that that's really what it's done for all patients, is really this culture change, right? This change in how we think about delivering cares. We don't want treatment to be just about following rules. We want it to be about delivering the right amount of structure and services and supports to kind of meaningfully and safely support someone in their journey towards wellness. And with the rule change, we certainly have that opportunity to deliver care in a much more person-centered way. And we're seeing the evidence of how that culture shift is positively impacting the patient experience. Also in our satisfaction surveys, we also use NPS, Net Promoter Score, and the stories that we hear every day.
Awesome. Thank you, Chrissy. And now we have our final question. What should states, territories, and OTPs be monitoring over the next few years to understand the extent to which these changes improve outcomes for people with opioid use disorder? Let's begin with Patty.
Sure, happy to, but I'm going to take advantage of the moment to speak to the matter of general monitoring of implementation. One of the biggest parts of the changes of Part 8 has been the focus on clinical judgment and the discretion that allows. So from a general monitoring perspective, I would say that we desperately want to remind everyone that the need for documentation is essential. The justification has to be well documented. Please remember, document, because you have to be able, whoever follows the patient needs to be able to understand what was the reason for the decision and the basis for it. So in terms of monitoring the impact of programs and states on implementing Part 8, I would say that some of the basic things that programs do already for monitoring quality improvement will be some of our most effective measures. There's qualitative part that I heard, patient feedback, which will be essential, getting patient impact. Having patients involved throughout the process of implementation will be important, but monitoring the patient feedback is front and center in terms of looking at overall impact over the years. The other measures we've talked about that are more quantitative, that are generally part of quality improvement programs, we've heard retention and treatment, reduction in use in terms of stabilization on current patients. And we've heard it said in a couple of different ways in terms of new patients. We know that a lot of the admissions, the OTPs have provided feedback, and some of the SOTAs, that a lot of the movement that's going on now, a lot of new patients, are people who've already been in treatment, but maybe one program has is more compatible with their personal needs, so they move to another program. But we really need to better understand, are we really getting the reach and creating the access to treatment that were intended? And so it would be important to filter out new patients, people who have never been in treatment before, people being captured by the increased number of emergency rooms that you're working with, the collaborations with reentry programs and skilled nursing facilities and residential treatments. Those will all show new patients, and that would also speak to some of what's more palatable about treatment in general, all of the complaints that we used to hear about this interferes with my life too much, and it was legitimate, but that's what will really show us the level of impact in the next 3 to 5 years.
Thank you, Patty. Next, we'll have Adam.
Yeah, and looking at really, how these changes are improving outcomes for people. I think Patty said it great, and I didn't even have that in my notes, that really just speaking to the patients. And I said we are doing those patient roundtables, but I think we need to continue having those discussions to see, from a patient perspective, how these changes are working for them. Are there other things that are needed? And then also, what I think is most important is looking at state data. Each state should really look at the data in regards to retention rates at really 30 days, 90 days, 180 days, a year's period of time. See if that has changed. Also look at trends in fatal and non-fatal overdoses. I know in our state, each of our licensed OTPs and licensed agencies has to report any kind of critical incident, which would include, a death of a patient or any type of overdose, even if it didn't happen at their facility and they are aware of it. And so, of course, one other thing I would note is really looking at really a lot of those national outcome measures, such as housing, employment. Have people been more successful? I know with, somebody not having to go in 6 or 7 days a week to an OTP, that gives you a greater opportunity to get employment and keep employment because you don't have to worry about, oh, I need to get to the opioid treatment program every day. So I think just looking at those are really the most important things to look at.
Thank you, Adam. Next, we have Chrissy.
Yeah, I guess just from the OTP provider perspective, I mean, Patty and Adam have already touched on a lot, but I do think it's important for providers to be kind of internally measuring what the impact has been of, induction strategies on retention, understanding the relationship between take homes on geographical reach of your program, on retention, on engagement in other services. Measuring your admission capacity, measure it all. But I also think it's really important that we begin to have some dialogue and consider how OTPs can measure things in the same way, so that we can really begin to develop and have some valuable industry level data.
Definitely. And finally, Dustin.
Agree, and agree. Adherence and total cost of care, I think, is something that we need to be looking at as well. On the OTP side, we know how important it is, and to have, I think Chrissy nailed it though, from our perspective, having uniform measures that we can look at and use is going to be so important. So.
I concur to that too. Thank you so much, Adam, Chrissy, Dustin, and Patty, for participating and providing your input on implementing SAMHSA's revised OTP regulation. It was very helpful to hear from you all and for you to share your perspectives that included federal, state, and OTP views. I will turn it over to Jennifer to conduct the question and answer portion of the webinar.
Hey, thanks so much, Nicole. This has been such a great discussion, and we've had so many good audience questions. Feel free to continue to add those to the chat. And I think that this is a good question to start with, based on the discussion that was just happening, maybe kind of a reframing of some of the things that we were discussing. But one attendee shared that, they're seeing patients who remain engaged in dosing, but maybe less engaged in other services. So given the revised regulations with how they're expanding access to medications, how are programs thinking about patient engagement more broadly now? So what does engagement look like now? I was thinking maybe this would be a question for Dustin and Christy, but anyone can feel free to jump in.
Yeah, I'll just start by saying, again, I think this is something that we should really look at, really measure, what is the relationship between, variation in take-home schedule and the patient's, not just their positive experience of decreased attendance, but how does that impact their experience of community at the treatment center? How does that impact their level of engagement in other services? But I also just want to say we have a lot more opportunities with telehealth, I think, in this post-COVID world. So, we're really trying to think about services not as not being so tied to the OTP hours. Really, you know, how can we meet that patient in their community? How can we do a telehealth? How can we deliver services differently? So I would also throw that out there.
And I'll add that this is the area that we need to be focused on as OTPs. The identifying why someone's not utilizing other services, not mandating that they do it, but figuring out why. We have information, we have assessments and tools and things that we could use to collect information to know whether someone is really in need of those services or whether, frankly, they're healthy enough that it's not necessary, which I think is really getting at the point of the regulations. Let's get the care and focus the energy on those who need them and not burden those that don't with regulations that frankly may even be harmful to them, making them do things that they don't need to do. Now, the OTPs, we really do need to be looking at why does this person need these services and how do we motivate them to do it? And if we're only looking at, oh, the counseling's not mandated, not required, it is, it's important, it's critical. It's now more important that you identify who and that you are working as a professional to motivate them into the care they need. When they choose that care because they feel it benefits them, that is a total different relationship with that patient than if they did it because they have to. One's checking a box, the other is actually walking down and doing recovery.
Great, thank you so much. Patty or Adam, did you have anything you want to add about rethinking patient engagement? Okay, I will move on to another great question. So one audience member asked, given significant workforce shortages for OTPs, how are programs navigating staffing requirements under the revised regulations? So, and is there anyone who can speak to sort of mechanisms for flexibility as programs do work toward full compliance for some of these requirements? Thinking maybe Adam, maybe Patty could speak to some of this.
Well, I would say with the regulations, they're not very prescriptive in specific staffing needs. So I think that's always helpful that, you know, OTPs can be creative in, you know, ensuring that all the services are met. But I do think these and I'll say in New Jersey, we had always had like more very prescriptive regulations in regards to OTPs. So I do think, again, it's so flexible, but that there is the ability to use a little creativity, but of course, still maintain all of the needed services that are essential at OTPs.
I would second that. The variations of requirements by state are significantly, there's so much variety. Part 8 does not speak very much to staffing, specifically what the rest of the clinic needs to look like. It does speak to the sponsor, it hardly speaks to the sponsors, it speaks to the medical director's role, and it also expanded staffing by making it possible for NPs and PAs, they're making it possible for them to use the full range of their skills, abilities, and training. But again, some states limit what an NP or a PA can do. So it's really more of a state and OTP-based question.
Great, thank you so much. And we have just a couple of minutes here, so I think I'll just ask one last question, and this is maybe kind of a multi-part question, but I thought it was very interesting. So we have an audience member that says, I work at an OTP and agree that these flexibilities are overdue and a welcome change, but there now does appear to be extremely wide variation between clinics in terms of internal policy. So I think this aligns with some of what we're discussing. So how can patients contemplating treatment or even non-OTP clinicians counsel patients about treatment and help with informed decision-making when treatment does look so different at different OTPs? So how could we arrive at some notion of a standard of care as relates to take-home decision-making?
Well, what I'll say is that I guess one of the things that I'm trying to do over the next 2 years is really just visit all of the OTPs and look at their policies and procedures and have sit downs. It's really hard, again, like policies and procedures can be more restrictive than what the federal regulations are, what the state regulations are. So I think it's really just important that, state opioid treatment authorities in other states really, look at their state as a whole. And I know some states are so much larger than New Jersey is. So they have so many more OTPs. So I think that's a challenge, but I think just sitting down, having those discussions, whether you have, like Chrissy said, like your local ATOD chapters where you can discuss some of these things. I know the state of New Jersey, we also have quarterly medical director meetings where we, share ideas, medical directors share their ideas. So I think that's really important, just hearing from other clinics of what they're doing, that things are safe, that there isn't as much liability as they think. I think that helps to promote change.
That's great.
And I'll add that there are, we have developed federal guidelines to be partner to the OTP regulations, Part 8. Those guidelines have been reposted and they were written for absolutely any public person to be able to utilize. And we'll get it in the email box, in the chat box yet. So we can share that.
That's great. Thank you so much, Patty. Okay, so with that, we are unfortunately out of time. Sorry we didn't get to more questions, but such a big thank you to all of our speakers today for this great discussion and for sharing such valuable insights on this topic from a range of perspectives. And thanks to everybody in the audience who joined us today. I hope that you all found this discussion just as informative and as encouraging as I did. So just as a last reminder, we will notify everyone when the webinar recording and those slides are posted to the SAMHSA website. Thank you all again for being here, and we really look forward to having you join us on future CFR webinars.
Thank you.
Thank you, Jennifer.